The Dentalpreneur Podcast. Okay, doctor, it's time to put down that handpiece. You're listening to the show dedicated to helping dentists get their lives back. It's time to decrease your stress, increase your profitability, and regain your passion. Now introducing your host, Dr. Mark Costas.
Hello, everyone. Welcome to another episode of the Dentalpreneur Podcast. I'm your host, Dr. Mark Costas. Hey, friends. I hope you're doing great out there today. Hey, listen, we got a couple of repeat guests to the podcast. We're going to be talking about lots of cool things today, but these guys are two of the most well-renowned and regarded surgical instructors and surgeons in the United States right now. Let's welcome back to the show Dr. Dan Briskie and Dr. Thomas Pfau. Dan Briskie is an implant-focused dentist and co-founder of the Colorado Surgical Institute, where he trains doctors nationwide in advanced surgical and digital dentistry. With expertise spanning full arch and implants, complex grafting, zygomatic and pterygoid surgery, and digital workflows, he combines technical mastery with a passion for mentoring and patient care. Dr. Thomas Pfau is a Scottsdale, Arizona native. He earned his doctorate of dental surgery from the University of Colorado, followed by an advanced training in dental implants, periodontal surgery, IV sedation, and extractions. A graduate of the Las Vegas Dental Implant Maxi Course and a member of the American Academy of Implant Dentistry, and also one of the hugely well-regarded mentors at the Colorado Surgical Institute. He also mentors dentists nationwide. All right, guys. How are we doing today? We have a very cool topic, and it's not like we haven't talked about this before, but there really is a never-ending amount of content to talk about surgical complications, prosthetic complications, dealing with unhappy patients when it comes to aesthetics or function. So those are kind of the things that I wanted to see if we could go down today and talk to some of the super GPs out there that I know are listening to this podcast about some of those items and some of those topics that they've run into, having gotten into surgery and integrating it into their dental practices, whether they're a brand new kind of surgically based doctor or an extremely kind of seasoned one as well. So we'll start with you, Dan. How you doing today, my friend?
Good, man. Just waiting by the phone, kind of like Tom. So for everyone that's listening, I'm supposed to have my first kid in 2 days. And then Tom is going to have his fourth child any minute now, also within the next probably 2 to 3 days.
Well, we have the beepers on. And we'll have some sort of an alert happen if it happens right in the middle of this podcast. We're ready to pivot if necessary. But yeah, great to see you again, Thomas. How are you doing, my friend?
Oh, I'm good. Just like Dan said, fourth time's a charm. I'm done. Okay, after this. So, but no, all good, Mark. All good, man.
It's great to have you here. So I'll let you start, Tom. There's some kind of basic case studies that you and I were talking about prior to flipping on the mics. One of the ones that I know happens a lot, it happened to me a lot when I was placing implants and doing surgical stuff in my practices, and that is dealing with complications due to atraumatic extractions. So exodontia, Dr. Dune and Dr. Briskie often talk about, the order upon which you should kind of dip your toe into surgery. And the first is always it's the starting point, and you have to be able to do a surgical procedure like atraumatic extractions very, very well before you start talking about advanced implant placement or advanced surgical procedures. So what are some of the things that we can talk to the super GP or the emerging implant doctor out there, or somebody that's just contemplating getting into surgery in the first place? What are some of the things that we should be looking out for and some ways to handle some of the complications that are bound to occur?
Yeah. So we were talking about, when you're trying to take a tooth out, I think, again, going for the basics, you're taking teeth out. How do we take them out without disturbing the surrounding alveolar housing that the tooth sits in, right? Obviously, different conditions as to why the tooth is being taken out, whether it's periodontal disease, root fracture, crown fracture, just deep caries, non-restorable due to caries, any of those things. But our main goal is going to be preserving the bone so that way we can place a dental implant in most scenarios. And if not, if you want to go with even just a bridge, still preserving that bone and that ridge is going to be beneficial for the patient. They're just doing a traditional bridge. Now, we were talking about how I had a case, I think is pretty common. So going from, like you said, from the beginning, even when you feel like you have the reps of taking teeth out well and not disturbing the bone and not breaking buccal plates, guess what? It's going to happen. I had a case. I feel like, again, I can take any tooth out and I feel like I can do it well. But this one was, one that you're going to run into. And it's going to be especially when you start getting to the point where you're doing more and more dental implant surgeries and you start dabbling into, say, immediate implant placement. Okay. The traditional extract, graft, come back in a few months, place the implant is super important and a super important foundation to, one, begin your surgical journey, establishing it within your practice. But then as you start to develop and want to progress into more advanced surgeries, those foundations are going to be crucial to now having the information to manage a intraoperative complication based on the foundational skills that you learned. So for instance, I'll take, you think simple extraction and grafting. Most of the time, sucker preservations, okay, if we're using, say, a non-resorbable PTFE membrane, well, we're going to create a little pocket where we're going to put that membrane on the buccal and tuck it over the lingual. And so you know how to flap, you know how to put the membrane, tuck it in, and basically flap the periosteum off the bone, put the membrane onto the bone, and then go ahead, place the bone graft, put the membrane over the top, suture it closed. Okay, seems pretty easy, but done well will help bail you out. In, for instance, say in a case like mine. So I had number 9 tooth was broken at the gum line. Okay, root canal treated tooth. So here's a warning to anybody who's taken out root canal treated teeth. You know that they're brittle. You know that the lack of blood supply seems to be more often than not that the bone fuses to that root surface for whatever reason. So it just makes it more delicate to come out, or it just breaks in pieces. Either way, again, something to kind of put your feelers up to be extra careful when you're taking that tooth out as root canal. Well, so my plan was I'm going to take the tooth out. There was no crazy infection, just was broken, non-restorable. So take the tooth out, put an implant in, and I was going to put a temporary crown. So I was going to put a crown on there because I feel confident and I feel also very passionate about, with immediate implant placement, being able to at least either place a temporary, or if I don't get good stability for like a temporary, at least getting a custom healing above it to preserve that gum tissue for future aesthetics. So anyway, my case was taking the tooth out, thought I was doing well. And as I took the tooth out, whole buccal plate fractured. So now I have this missing buccal plate. Now, what do I do?
Yeah, good question.
So, okay. So, if this is the first time happening to you or any complication that happens to you, just take a deep breath and stop for a second. Take a deep breath. If the patient is sedated, great. You can say your expletives, right? But if the patient's not sedated, then just take a deep breath, gather yourself, and then try to assess what's going on. So now treat this as if you were taking out the tooth and you're just doing the extraction and ridge preservation with bone grafting. So perfect. So extend your flap if you need to, or if you need to extend it more apically to get to the bone, to where you're seeing the bone, you know where that buccal plate fractured at, you know where your boundaries are. So now, with that being said, you can look at, okay, where am I going to place this implant? And should I abort this? Well, when I looked at it, all the rest of the alveolar housing was good. So the interproximal bone wasn't fractured or broken. It was just the buccal plate. And I felt very confident that placing the implant, obviously more palatal in its position, I wasn't going to violate the ability for bone to properly heal around this implant by placing it too buccal, because if I placed it too buccal and outside of the alveolar housing, then you can't graft onto it. You can't successfully place bone that has implants that are exposed past that alveolar housing in a buccal lingual dimension. know it's hard to say that audibly, but I hope people can get that. So I felt like, okay, when we place more palatally, it's going to be completely encased in that socket. I have at least 2 to 3 millimeters of a gap between the palatal and the buccal, basically border of where that buccal plate fractured at. So I knew that as long as I place the implant in the right location, I can then graft this and do a ridge preservation and then close this, use my temporary abutment or temporary crown, and this patient's going to heal just fine. And which is exactly what it did. So I was able to put the implant in. I was able to put a nice, temporary crown on it. But obviously I put a resorbable membrane, put it past the apical portion of the buccal fracture in my flap, put bone in, sutured it, all good. And it healed fantastic and no issues. But without my foundation of taking out teeth and doing ridge pressurations all the time, I wouldn't have known, or I wouldn't have felt confident being able to manage that because I wouldn't have seen the outcomes previously. So I think, Dan, you can talk on this too, where it takes experience or it takes knowing somebody that has had the success with cases like this to feel confident in knowing what you're doing is going to succeed, even though all the literature can support your decisions, which is great. But a lot of us clinicians, we want to have a history of things going the right way or the way we want it to go to feel confident that we're going to achieve the results that we're looking for. So I knew that. I've had many cases where my buccal plate fractured on just regular extraction sites, number 30, number 19, number 4, number 5. And I did the same grafting that I did and preserved a nice buccal and regrew this buccal plate and was able to place an implant, after it healed for a few months. So I knew, biologically speaking, what I was doing was sound and the technique was the same. I incorporated an implant placement and a temporary restoration on it.
Yeah.
Tom, what membrane did you use for that case?
Great question. So in this one, I wouldn't use a non-resorbable membrane. So for most extraction ridge preservations, my go-to was the Cytoplast PTFE. Still is a fantastic membrane. I think is really, really good. Okay, but what I did was I used a kind of longer, collagen membrane. So a resorbable collagen membrane, not a collar plug, not collar tape, but an actual collagen membrane that's going to stick around for a few months. Okay. So that way, what we're trying to accomplish here is we're trying to prevent epithelial migration that will get into the implant area. So your bone graft is there to hold the space, to grow bone in the way, again, that you want to grow bone in, brain fart, because it's osteoconductive and it's a scaffold. It's going to hold the space and allow for new bone formation to happen around that implant. And the membrane is going to prevent the epithelial migration from getting there quicker or getting there before the bone has a chance to mature and grow. So yes, resorbable collagen membrane. Also, big key with this though, with PTFE membranes, you leave them exposed on socket preservations. But in this, you don't want it exposed. So you want to make sure that your buccal tissue, that there's no exposed membrane to the oral cavity, because what can happen is those things can get infected real easily with bacteria from the oral environment. So you want to make sure that's sutured nice and tucked away, so to speak, so that way you don't have exposed membrane out and about to get gunk in it and then get infected and then screw up your surgery.
Did you do a healing abutment or a cover screw on that case?
I did a temporary crown, so I made a custom temp. Yep, so I did a custom temp, and that's what I do with all my immediate implant placements if I can. And like I said, if I don't get my stability over like 35 centimeters, and say if it's like 20, what I'll do is I'll just do a custom healing abutment. So I'll do the same process, but I'll just make it flush with the gum tissue and not a temporary crown.
Okay, sounds good. So for everyone listening, I want you to picture this. If you're going to use or it all depends on the closure. If you can close something 100%, then you can use collagen. Okay. If you can close an incision line within 2 millimeters, then you can also use pericardium. Pericardium can only be left open 2 millimeters before it would dissolve, basically, right? Before biology can attack it. So collagen has to be closed completely. Pericardium can be left exposed 2 millimeters, or bioexclude is another one, and Cytoplast PTFE. So there's 4 main groups or things that I would recommend, right? It's collagen, pericardium, BioExclude and Cytoplast. BioExclude and Cytoplast are unique because they can be used when the incision line is open, 100% open even. Huh. You could drape BioExclude, which is a really nice piece of placenta, basically, over the top of a bone graft, and it will heal even if it's open. It's excellent product. The only other way to graft something at that moment, if the incision is opening, is adding a Cytoplast PTFE, which is a non-resorbable membrane. So just again, like if something's closed, you can use collagen or pericardium, but if something's open, you only have two choices. You can use BioExclude or Cytoplast. That's what I always tell people. Just like to keep it simple. Those are like my favorite ones to use.
That's cool. And how long is healing for that, Tom, as opposed to a typical non-complicated immediate implant placement?
The same healing time.
Oh, really?
Yeah. So I every 3 to 4 months.
Okay. Very interesting. That's cool. So let's make a like not so subtle shift to kind of prosthetic stuff that you guys are seeing. And again, in the spirit of talking about things that the GP, whether a seasoned super GP that does a lot of surgeries versus somebody that's relatively new to the surgical arena, what are some of the main prosthetic challenges that you see people run into or that you run into on a regular basis that your experience has helped you to be able to navigate without a panic or a holy crap situation?
Want me to take this, Dan, or you?
Yeah, you want to start?
Okay. So one of the main ones that I have run into is with single implants, so the screw stripping. So I think all of us have been frustrated that whether we're trying to seat an implant crown or remove an implant crown on the implant, or even a cover screw or but a healing abutment, screw strips, what's going to take most of your time? And I think it's simple things like that really you feel like are easy, but then when there's an issue with it, so say like a healing abutment removal, and an assistant's working for 15, 20 minutes trying to say on your schedule, get the healing abutment off and put the scan body on, take a scan, get ready for your implant crown, and off we go. Well, now you're wondering why your assistant's there trying to remove the healing abutment for 20, 30 minutes and hasn't come and got to you, and now realize that everything's stripped. Well, most of us, so say if it's a healing abutment, all right, well, I think most implant docs will know this, but if you're just coming up, you have a great burr, which is a 330 burr, and you can make a slot into that healing abutment, and you can take simple flathead screwdriver, or you can take a crown removal, which is simple, looks exactly like a flathead screwdriver. You make your slot in that healing abutment, and then use that crown removal tool to back it out. Really easy fix, something that can, just get it done, move on, and get a new healing abutment, go from there. The next would be like an implant crown. So an implant crown, the assistant's trying to remove it or for whatever reason, or you're trying to seat it and you can't get it out or whatever, or you got a patient that, has implant was 10 years ago and now it's loose, and you go in and remove and are looking at it and trying to figure out, okay, say, the implant brand and you have the right driver for it, but now it's not working, or you got composite, they didn't pack Teflon into the access hole well, and you got composite over a screw. What do you do? Because that's going to be the biggest time suck out of your life. Okay. The biggest tools that have helped me try to stop fiddling around is if it's nothing's working in like 1 to 2 minutes of what you're trying to accomplish, then do something else, because nothing's going to just magically get better just because you tinker with it for 10 minutes and doing the same thing for 10 minutes. It's not going to happen. So the biggest thing is like, all right, do this. If it doesn't work, look, you have your magnification, look inside. If you can see the screw, see it stripped, fantastic. There's a ton of implant solutions, implant kits that have screw removal tools that you can put on that have, the threading in the opposite direction, which is able to bind. So, as you try to loosen it, it engages that screw, that prosthetic screw is able to back it out. That thing saves my butt more often than not. So really just knowing when to use, to say like a abutment removal tool or a screw removal tool, not a fixture removal tool. So fixture being the implant itself, but a smaller one that has threads in the opposite direction is one that's really going to help you out on those single implant crowns that you're like, okay, I can't get it out, or I can't get access to it, or the screw is stripped. And worse comes to worse. I mean, I've had to, unfortunately, the screw is so stripped that won't work. And I tell the patient, guess what? I got to cut this thing off. And so we basically have to take 702 burr and cut that whole entire crown off and everything. And then, fish out the rest of the screw there and make them a new one.
With these, sorry, go ahead, Mark.
No, I was going to ask, you're probably going to get to this in the second part of the question, Dan, but I was going to ask, what if this just happened to one of the CSI patients that came in last time I was there? What happens if the screw actually breaks and you don't have access and you can't make a slot because there's no top to the screw at all?
Implants coming out. Yeah.
Okay.
So to be really realistic to people listening, if you break a screw inside of an implant, the chances of you getting that out without damaging the implant is probably under 20%. That's what some of the higher ups Neodent have discussed with me. Okay. It's almost hopeless a lot of the time. It's kind of sad to think about it, but just waiting for an implant retrieval kit from the manufacturer is not going to really help you.
Yeah, you're just procrastinating.
I'm just honest. Yeah. Usually the implant needs to come out, and you're probably going to take a trephine to take the implant out, and you're probably going to graft it with a non-resorbable membrane, and then you're going to repeat your implant later down the road.
Got it.
Because so many of these screws can strip so easily. And what Tom said, if you don't immediately feel like that the head of that driver binding, you should not continue doing anything, because most of these screws are friction grip. So a Neodent screw, let's just pick that because it's very popular, right? The dimensions of the screw are 050, but then the driver or 1.27 it's called. But there's two different types of 050s and 1.27s. There's one that has a straight wall, and there's one that's a friction fit. So if you stick a friction fit in a friction fit screw and you don't really have it binding well, you can strip the top of it very easily, right? Or vice versa, if you have a true 050 and you stick a friction grip in there, you can also strip it. So it's you can strip things so easily. And it's just important to realize as soon as you strip it, do not mess with it. Also, too, when you're torquing things, and whenever I have had a broken screw, it's always been a situation where I actually didn't do it. It's just because I accidentally let an assistant torque a screw, and they went beyond the manufacturer's settings, and now we're either stripping it or the screw is broken itself. So I always recommend everyone that's listening to in your practices, when it comes to final torquing of prosthetics or crowns or anything, make sure it's you who's doing that. They can do the try-ins, but in terms of the actual final torque of the screw, please make sure that's done by a doctor. There's actually also a lawsuit that I remember Vichy Broman telling this story, where there was a doctor who they had a final wall annex. The assistant torqued the screws, and then the doctor got sued because the assistant delivered the final.
Yeah.
So it's that's just that one piece of evidence is just enough evidence to, not let that happen to you. So final torquing of things, I always recommend it to be done only by the doctor. So let's say you do have a screw that starts to strip, right? It is important to just stop right away. I'll grab my universal implant driver kit, and then I'll try a few different ones in, right? Because sometimes you'll just get one that fits just a little bit better, right? And then boom, you're good. But you definitely don't want to be sticking the screwdriver back in there and freak out and just start stripping it even more. Because if you have right angles inside the screw head, if you keep turning it, they all become round, right? If it becomes too round, now there's nothing that's going to save it. So the two drivers that I stock in my practice now are, I have a flathead screwdriver that actually can fit inside almost any button and screw while it's becoming stripped before it gets to a circle. Then I can back out the screw. So I have a flathead, actually, a small flathead latch. And then a Torx driver, which is a T9, the one with the ball on it. The angled screw channel ones are actually surprisingly really good for getting out strip stuff. So I'll try one of those too, and it almost always works.
Cool. Is there, I'm not going to throw anybody under the bus, but is there, instead a brand that you prefer instead of saying the ones that typically strip or break? What is the brand that you prefer that where it's less likely to happen based on your experience, Dan?
Yeah, like a Norris
Okay.
implant.
Mm-hmm.
Like the connections are just so amazing. Like there, you can crank on them, you can screw stuff in. Stuff just never breaks or fractures. Tom will probably agree with me on this because he and Clark will teach like a pterygoid or zygoma class. You can crank on those implants and things just don't strip or break. So I think one of the critiques of many implant companies right now are that the parts can strip too easily. And I would agree with that.
Such a huge complication. Stripping is one thing, but breaking is just, it's the death nail.
Yeah.
It sucks.
Yeah.
So much.
It does suck when everything surgically went super well and then prosthetically a piece of instrumentation breaks. That's beyond frustrating.
Yep. And it happens. It really does.
Yeah.
Especially when you're doing full arch and you have your multi-unit abutments, screws breaking multi-unit abutments. Yeah. That's good times.
Yeah. Good times. All right. So let's transition one more time. So Tom, you were telling just a quick story off air, and you probably weren't expecting me to ask this on the podcast, but what happens when somebody is, well, one of the complications and one of the most difficult things about dentistry in general is managing patient expectations, right? And then we have, without building in and just an automatic kind of excuse that all patients are crazy. We are going to have to deal with people that have unrealistic expectations, even if they seemed reasonable prior to surgery, when you get to the prosthetics level. You were talking about one particular case where everything went smoothly from a surgical perspective. It went great. But when it came to prosthetics, the person became unreasonable, and you had to deal with the psychology of dealing with somebody that doesn't seem like they're going to be happy no matter what it is that you do. So we've all faced it. Anybody that's been in dentistry for any length of time, whether it's veneers or crown and bridge or any type of restorative procedure, you're going to face that. Of course, things are magnified and they get more serious when you've put a significant amount of effort to the surgical side of an all-on-X treatment. What do you do personally when you get somebody that is just super unhappy with the aesthetics? What does the conversation sound like, and what's your course of action before things go kind of even further in the wrong direction?
Yeah, I'll definitely touch on this. This is a good story. I like what you said too, Mark, which is we all deal with it, and we've all dealt with it as practitioners. I would say that when this is obviously a full arch case, I feel like some full arch patients, because of the money that they're investing into this, their expectations, no matter what you tell them, are a little bit unreasonable. And I think doing your best to set the expectations as best you can will eliminate 98% of the issues that you'll have. But like you said, this instance, this case, I'll tell you about it. So patient, had rampant decay, and she was just really looking forward to being able to have a new smile. Younger female, in her mid 40s, and surgery went great. The way we do our temporaries, we do an acrylic temporary analog conversion with the NeoConvert system. And I tell people for 3 months, this is your temporaries. Don't worry about if something's off, because in surgery, we're hooking things up. Your midline may be shifted because you're under anesthesia. Your bite may be a little bit off. That's okay, right? That's pretty common. So don't be alarmed. We'll be able to fix it at 3 months after everything's healed. We'll be able to get back and be able to deliver, and start making prototypes, with the PMMAs, and then your final zirconia will be exactly what you or have wanted. In this instance, this patient immediately from surgery, he came back for their 2-week post-op and said, "I hate these teeth." Okay, this has happened before in my practice. What we end up doing with a patient like this is we kind of rush them into their PMMAs. So, we take scans, we take photogrammetry, we do our setup that we normally do at the 3-month mark. We do it as soon as possible. So perfect. I said, "Hey, don't worry. we'll take care of you. I know you're unhappy. Okay, so that was the first interaction. Not a big issue. So we get the scans. We go to deliver the PMA in about 2 to 3 weeks. Well, we deliver this, and she is hysterical, screaming, crying, and just yelling at me and my assistants about how terrible her teeth are and that she cannot go out in public like this. This is miserable. And it just making a complete scene in this office. I mean, the most hysterical individual, or most hysterical I've seen an individual. Okay. And to me, I was like, oh my gosh, all the hard work that my team and I made, to get her going, to do this for her, instead of being like, hey, you're being unreasonable here. That's not what was going to happen. Mm-hmm. In this scenario, the way I've managed this situation in the past, and obviously this was an extreme, was I just let her tell me everything that went on. And I said, hey, I want you to tell me everything that you don't like about this team. I want you to be as specific as possible. I want you to tell me every single thing. Keep going. And when I asked her, when she said something, I said, keep going. Tell me more. Tell me more. I had my assistant write everything down. And so instead of being defensive on our end, which is, as dentists, I feel like a lot of the time, and we're like, hey, this is really not bad, or we work really hard on this, like, you should kind of meet us halfway. Well, that's not going to happen with everybody. And unfortunately, due to fear or due to expectations, where she was thinking she was going to get perfection on this set. And whether that was not communicated properly to her, which I feel like it is, but even then, it just was a reminder for me to make sure that we communicate properly with the patient and saying, this is a temporary set that we will make sure and make adjustments to. It may not be the perfect set right away, but we will work on it. To her, she felt like it was going to be perfection right away. And because of that, that was immediately, she felt distrust in every one of us. Mm-hmm. She felt like everything was wrong. She felt like she couldn't trust a single thing that we were going to do. So instead of just defending, flipped it around on her and said, hey, tell me everything that's wrong with this. So that way we're on her team and not one against the other. So when you jump on the patient's team about their frustrations, even if it hurts your pride, which it sure did, mm-hmm. Absolutely. But when you jump into their position and go on their team of, hey, what are we going to do this together, instead of, no, Mrs. Jones, this is exactly, no, you're out of line here. Okay. But that was a way that, I just got her in. So this was, maybe last week, I just got her in because the second set was better, and then she had more things, and she ended up being really, really great. And we got her in a set now that she's really, really happy with, and she was crying and so happy with, right? But it wouldn't have happened if the team and myself didn't jump on her team. If that makes sense. Yeah, totally. And really advocate for her and for what she wants in this, knowing that we can deliver what it is that she wants. Yeah. I really like that. And you use the term off-air de-escalation, and you're from the military, and that is from a military background, and that is a very, very important point in any type of negotiation. But acknowledgement, getting curious, and giving the impression, not even the impression, but the actual reality to the patient that they are in control. Look, you have complete control of this process. I'm curious. Let's find out exactly, you handle this really well. Let's find out exactly what it is that's making you unhappy. And point by point, we're going to do our best to rectify that situation. And you are so right. And that comes with any kind of communication and psychology with humans in general. The minute you get defensive and start trying to defend your position and making them feel like their feedback is unreasonable, that's when things are going to spiral out of control, and you will not get that patient back. But if you take a step back, put your pride and your ego aside, and literally get curious, lead with questions, and allow them to talk all the way through, no matter how irrational it might sound to you, I think that's a really important part in aesthetic dentistry in general. Go ahead.
Go ahead. That was fantastic, because one of my I'd say one of my flaws as my personality is, when I hear a problem, I try to find a solution. Yeah. And a few years ago, I realized that I need to stop finding solutions and just listen.
Mm-hmm.
And the moment that I did that, everything got easier. So I have to always ask myself, like your situation here, it's like, am I actually supposed to find a solution right now? Or am I supposed to just listen?
Mm-hmm.
Right. And that patient was not looking for a solution whatsoever at that moment. They were just looking for you to listen, feel like you care. And sometimes it's just a feeling, right? And then once they feel like you care, you're all of a sudden back on their ship, right? And you can get to a solution really quickly. So I really love that. I think everyone out there can be better about just listening, not finding solutions, being humble, right? I do kind of the same thing as you, Tom, and I just listen when those things come up, and I do a whole second visit as a sit down to talk about what I can achieve from their list of concerns, right? And then you just figure out where to go from there. But yeah, really nice, nicely done. Very nicely done.
There's a book out there. If everybody reads it, it's called, it's a negotiating book, but it's Never Split the Difference with Chris Voss.
Mm-hmm.
And that's such a great book. If anyone wants to read it or listen to an audiobook, it really gives you some insights into just psychology itself with people. But I also put myself in the patient's shoes. And I think sometimes it's good to do that. And sometimes I think it's good to have a healthy boundary distance, because obviously if you care too much, then maybe you're not be able to make the right decisions. But in instance, I've had, again, this isn't the first time this has happened with a patient, and I'll be honest with them too, where I had a patient, they're temporaries. They came in there 2 weeks and they're like, these look awful. And I said, yeah, they do. And really, it didn't look good. You spent $45,000 on this. This is not the quality that we can do for you. Okay. And I agree with them. But in my back of my mind, I know, okay, I agree with you. Here's how we're going to fix it. And that de-escalates every situation almost every time. Instead of me being defensive, I agree with them. If I really do, right? If I look at it and I go, ooh, boy, that temporary conversion was not very good, or these teeth that they picked out, it is not really good. And if they're really unhappy with this, then we can fix it. But I agree. And so really, really making sure to, it just goes with everybody. It's been huge for me to swallow my pride. And it's like you said, Dan, when you listen, good things happen, and people are more craving a human interaction with their doctors instead of what they get normal healthcare system now, which is they get maybe 5 minutes with their physician and then get shoved out the door. Mm-hmm. Where we have a unique ability to spend the time with the patients and to really deliver the care that we would want ourselves. Mm-hmm. and the relationship that that they deserve, especially when we're doing something that costs a car, an expensive car. Right.
Yep.
Yeah. And Tom, you alluded to the kind of the opposite, which is patients. You can also encourage your patients to be too picky.
Yes.
So there's a middle ground, and Tom listens when he's supposed to be listening, but also he's trying to move his patients along, because patients who have bad teeth or are not getting it right. If you have bad teeth, there's a lot of things wrong in your life, right? People look at you funny. They don't sit next to you on an airplane. Right. There's so many little things that happen, and you're going to have traumas, and everyone loves to ruminate on their traumas. Mm-hmm. The difficulty is we're supposed to help patients move along and not ruminate on traumas. So at the same time, we're trying to help patients progress through the pipeline of getting your teeth done, and you can finish with your life and not ruminate on traumas. But at the same time, when things pop off, right? And time to de-escalate the situations, it's important to notice that.
So I'm glad you said that, and I want to tell the docs what I do, which is super, super helpful, because you're right. When you give patients too much control, they don't know what they're talking about. Sorry, like you don't understand aesthetics. You don't understand what we learned in dental school, especially cases that require aesthetics. Yep. So, full arch, whether you're doing full mouth veneers or you're doing what Dan and I do a lot of time, which is all of our full arch. I tell patients from the minute consult, or the first consult, I say, guess what? I'm the captain of the ship, and you are my first mate. Okay, I'm going to guide you into where your teeth, occlusal function-wise, is going to be proper aesthetical function or aesthetics function based on Goldman proportions and everything else. And then also, I'm going to look at your face. I'm going to look at the shape of your face, the size of your face, your buccal corridors, how big you smile, how wide you smile, where your teeth are going to set, how they're going to look. I'm going to get all that there. And then your job is to tell me the minor tweaks. Okay? And when I say that from the get-go, they know that, hey, I'm in charge, but you are helping this whole situation, giving you control, right? But also making sure that you don't get them to the point where they're just going to continue to make change after change after change just because they can and because they can't decide what they want.
Yeah. Yeah. It's interesting because I've heard you, Dan, talk about this in kind of your lectures before, talking specifically about case selection. And we have these built-in filters, you know, these subtle cues that we can pick up, and sometimes not so subtle cues. If somebody's like overly complimentary or overly critical of previous dentists in the past, if they're overly complimentary to you and they've known you for 3 minutes, sometimes that could be a red flag as well. But you know, just for the sake of reviewing that, Dan or Tom, what are some of the red flags? Clearly, this particular patient got through your filter, Tom, your typical like case acceptance filter. But what are some of the things that are pretty obvious that'll kind of steer you away from doing this type of case on somebody during the initial consult?
All right, I'm gonna say one, and then Dan, you got one. It's gonna be like back and forth. I'm gonna say one, then you say one. Okay. So the first one that is our biggest red flag is them talking crap about the other dentist that did some of their work. And when you look at it, it really wasn't that bad, but they're throwing everybody under the bus.
Sure.
No matter what, it's their problem, it's their issues. They don't take ownership of anything in their life. Mm-hmm. And you'll know right away, those people. So if they're blaming everybody else for it and they're like, oh, well, you're the best, you know, I just heard you're the best and you're going to fix me up right. And, you know, I knew I came to the right place. You guys are fantastic. And this guy was terrible. He messed up my mouth. That's one of my favorites. He messed up my mouth. He jacked it up. I'm terrible. I'm never going back to him. But, oh, Dr. Fowl, you just, you know, you're going to be so fantastic. I just know I'm in the right place. When I hear that, no. Go ahead, Dan.
The natural inclination is to lean into that, right? A less than seasoned operator would be like, "Oh, this is great. She thinks I'm awesome," and I'll agree with her. That guy probably was a hack. But when it all comes down to it, the general rule of thumb is if they're going to be throwing everybody under the bus immediately, or overly like ridiculously complimentary to the previous guy, there's two things that are happening there. They're either not accountable or they refuse to take responsibility for their own actions. They have a permanent victim mentality, or they have an unrealistic expectation on what you can deliver based on their beloved doc that they had to leave for whatever reason.
Hey, you know, ladies out there, defend me here a little bit. You got a guy that's coming up to you trying to, you know, at the bar or something and just starts spewing all the compliments on you, just overdoing it. Come on, you know this guy's a schmuck. So same thing goes with patient care. Come on, the patient's talking you up too much and they don't even know you. Get out of here.
Yeah, exactly. All right, your turn, Dan.
Let's see. Other ones are patients who, one big flags for me that I watch out for are patients who are nice to me that are not nice to my staff or the people on the phone call. I had my staff tell me who's like rude to them on phone calls ever. And we just decide there if we want to have this patient join the practice or not. Because nowadays, I think the ones that I would get in trouble with were also the ones that I feel like I could save, right? Like I had this amount of empathy for, oh, I can save this person or I want to help them, but it's just not possible, right? Like, and you can't save people. And the more empathy you have, you'll make worse decisions, is what I've noticed over the years for myself too. So if I feel like I have an overwhelming connection to something, and then I need to put the feelings aside and look at it as black and white, because in dentistry, things are more or less black and white. There's not a ton of subjectivity to this, right? A lot of things are objective. And when patients are just rude to staff or rude to someone, and I didn't notice that, I think that's a major red flag. And I actually try to steer them away from the practice.
Yeah, that's a big one.
Next one would be people who are price shopping and trying to make a deal, which, listen, I like to get deals as much as anybody, okay? But when they're really haggling for something, I know that they're not valuing what we can provide. And also it may, like early in your career, you may just like, I need this case. I need it so badly, right? Okay, I can do this for a discount. Or, you know, this patient really, really is haggling me like, okay, maybe I'll just give in and we'll do it. there's some leeway here and there. I think Dan, has touched on it before in previous podcasts and previous lectures where, if it's an insurance issue, you can knock off a couple $1,000s on the treatment, just as a good,
good faith,
goodwill for the patient.
Yeah. Mm-hmm.
Right. That seems pretty reasonable, but people were really haggling. I see that as a big red flag because they don't value the treatment and they're just shopping around. And if they're shopping around, then they're a consumer and they're not going to really be happy with what you get because that's just who they are.
Yeah. I had a patient a few days ago, came in for a consult, needs almost 9 or 10 crowns, a couple root canals, bunch of fillings. She comes in talking crap about Comfort Dental. Right. And then she's like, hey, I need a better practice. So I looked you guys up. You have all 5 stars, like 300 5 stars. I thought I'd try you guys out. And then guess what she said at the end of it? She said, you guys cost too much. I was like, all right, what are you talking about? First of all, I don't. These are insurance fees. So they're going to be the same no matter where you go. So what are you looking for? If you're looking for another Comfort Dental, then go back. Right? Some DSOs are good, some are not. Some private practices are good, some are not. Right? But if you're looking for high quality of care and you think you found it, maybe don't resort to the cheapest option again.
Yeah. What is that saying? That price, time, and quality, you can only pick 2?
Yeah. Yep. Yeah.
Yeah. So it's a fast, cheap, and good, right? So if you want it fast and good, it's not going to be cheap. Yeah. And if you want it fast, or what would you say? So fast. Yeah. Those 3. I'm screwing it up now. Thanks.
Well, awesome. Well, fellas, that was good, man. I can't believe a whole hour's gone by already. Thank you guys so much. Dan, is there anything that you want to share about upcoming CSI courses? By the time this hits the airwaves, both of you guys will be with brand new babies. So I'm sure that we have to work CSI courses and what you guys are teaching around a brand new human that's come into the world. Congratulations to both of you. But what's happening at CSI, whether or not you guys are going to be there to be mentors?
Yeah, of course. So I'd say the biggest or the coolest change is going to be our implant complications course in November. That's going to be the biggest one, or the most important one, I'd say, for this year. The other additions will be more of our implant and wisdom teeth foundations classes. So we're going to start offering just the clinical without the hands-on during our bigger weekends. Mm-hmm. So that way you can get all the information you need over a weekend and see the cases. Because I've noticed over the years that there are a lot of people who just don't know if they're ready yet for the hands-on, right? Or feel like they even need it. So now we're going to start to offer the classes without the hands-on component during our big CSI weekends. So you can still see the implant placements and gain the knowledge.
Awesome. Really good stuff. Well, gentlemen, can't thank you enough. And that's coloradosurgicalinstitute.com. All spelled out. CSI is not ours, is not our URL, coloradosurgicalinstitute.com for all of the courses that are coming up. And you can communicate with our team at CSI through that website. Thank you guys so much for all of your expertise as usual. And congratulations once again to the addition of families.
Appreciate you,
Mark. Thanks
so much, man.
All right. Yeah. Ladies and gentlemen, Dr. Thomas Pfau and Dr. Dan Briskie.